Welcome to Praxis. I'm Olivia Rousset. I'd like to welcome our audience here in Sydney, as well as those watching on APAC, online, or listening on radio. Today we'll be discussing HIV in the developing world. Throughout the discussion today, I'll take questions from the audience. On our panel, we have Rouena Getigan. Rouena is the International Program Coordinator at ChildFund Australia. Bruce Parnell, who is a Principal Fellow at the Burnet Institute and convener of the Burnet's work in HIV and international development. And Bill Bowtell, who is the Director of HIV/AIDS Project at the Lowy Institute for International Policy. UNAIDS and the World Health Organization estimate that AIDS has killed more than 25 million people since it was first recognised in 1981, making it one of the most destructive pandemics in recorded history. Health statistics show that the poorest regions of the world are also the most affected by HIV. More than 68% of people living with the HIV virus live in sub-Saharan Africa. During the last 2 decades, the World Bank has provided $4.5 billion for HIV prevention, treatment, care and support programs in developing countries. And there has been progress. After decades of increasing mortality, the number of AIDS deaths globally has declined in the past few years, partly as a result of greater access to treatment. But for every 2 people put on antiretroviral drugs, another 5 become newly infected. The key to reversing the epidemic is to prevent new infections. The 6th Millennium Development Goal is to stop the spread and begin to reverse incidences of HIV by 2015, as well as to provide universal treatment. I'd like to ask all the panellists, how much are we on track to achieving this and what more needs to be done? Firstly, Bill.
We are doing much better than we have ever done before, thanks to the fact that after the first 10 or 20 very chaotic and unsatisfactory years of the global response, we did light about 10 to 15 years ago on the strategy for dealing with HIV in all of its forms, care, treatment, prevention. And then what came along about 10 years ago was a large amount of extra new additional resources being found to put behind that strategy. The World Bank, as you mentioned, came to the party. The American Congress under PEPFAR, which is a $50 billion program on HIV and AIDS. And most importantly, in my view, the Global Fund came into existence, which has mobilised another almost $19 billion in the last 10 years. And of course, the big bilateral donors in Europe, Australia and so on have all come behind a coherent strategy. So we are getting on top of it. It is starting to turn around in many of the worst affected areas, sub-Saharan Africa particularly, where the problem was really of a huge magnitude. But the overall satisfactory decline in the general figures masks very worrying developments in such areas as Central Asia and the countries of the former Soviet bloc, where thanks to unsatisfactory laws and so on, the HIV spread is not under control. So we're doing okay, but there's a lot more that needs to be done, and the key to that, I think, is a large amount of new resources behind care and treatment on one hand, and most importantly on prevention.
Thank you. And Bruce?
I think my response to that is to be fairly confident that we are on track to meeting that Millennium Development Goal, partly for the reasons Bill's saying, is there have been a lot more resources put into it, but also because our understanding's improved enormously, even since the Millennium Development Goals were formulated. We now understand that there are different epidemics in different countries, so not every country in the world is going to go the same way as the Southern African countries, where it explodes and becomes something that affects everyone. I think we're being very successful just within the last 3 years or so in Southeast Asian countries with getting governments to understand you do have sex workers, you do have injecting drug users, not in every country and not in every part of every country. You do have men who have sex with men, but they're not always visible, like a gay community might be in a wealthy country like Australia. And so we're seeing in Southeast Asia a lot more of these new resources being put into the groups at highest risk, and with some success. Likewise, our technology in treatment has vastly improved. The numbers of people who require treatment, the number of them who are on treatment has substantially increased. The treatments are better than they were even 10 years ago, fewer side effects. There are now new global plans to put people on treatment much earlier, before they even become sick. And that has a huge impact on reducing people's viral loads, the amount of virus in your body, and that in turn has an effect on prevention. So for reasons of political commitment, extra funding, but also improved understanding, I think we're well on the way.
And Rowena?
I think there's opportunity to scale up in order to reach that point where we achieve the MDG 6. There is still a big role for the international communities to continue the expansion of prevention and control programs and address the need for highly skilled health personnel, especially at the community level. And yeah, the comprehensive access to HIV and AIDS treatment.
And Rowena, your experience is primarily in Africa, working with orphans and vulnerable children. Mm-hmm. Can you outline broadly, and then we'll get more specific about what ChildFund do for orphans and vulnerable children?
We have this program that we've been implementing for the past 6 years now, and it's taking place in 3 countries of Africa, like Uganda, Zambia, and Kenya. And it's focused on enhancing community care and support systems, with a particular focus on psychosocial programs. And the aim of this program is to reduce the impact of HIV and AIDS on children and youth. And what we do is work with the multiple stakeholders at the community and district level. Stakeholders meaning faith-based organizations, government personnel from the health agency, education, sports commission, religious leaders, chieftains in the village. And there are also youth groups and women's groups in those networks.
It's a huge proportion of children who are affected by HIV in Africa. What's the primary? You say psychosocial. Obviously, there's a whole lot of practical issues to solve about where they're going to live, how they're going to be educated, what food they need. What are the primary psychosocial issues that you find they're faced with?
I'll answer that question by sharing a story that we encountered in the field. There's this 7-year-old boy who lost his father and a younger brother to an HIV-related illness. And the mother took on the responsibility of raising the whole family. And he helped out by taking on odd jobs. And because of that, he started missing out on schools, on attending schools. And he was taken on by his grandmother, who thought that he's being neglected. But he had a hard time coping with the deaths in his family, so he started skipping school and escaping from home at night, and this caused some conflict between him and his grandmother. And there's another one who lost both parents, and again taken on by a grandfather who's already taking care of 12 children. And he's a subsistence farmer, and it took a lot out of him, like financially, and he's not able to provide a quality support and care to all those kids. So that boy felt that he's quite isolated. He doesn't have anyone to talk to, even his teachers. And in his experience, his classmates children in his school are laughing at him because he lost his parents to HIV and AIDS.
So what programs, what have you found useful in supporting the kids in dealing with the...
The program is targeted at different groups. First are the service providers who were trained on various development skills like networking, resource mobilization, psychosocial support, which is very important because there is a tendency to provide more, to focus on the physical needs of children, but the psychosocial aspect is quite weak. So it's important to have those skills, but wherever you are, or whether you're from the community or from the school, or someone who's working in the at the minister's office, you have to have that background on psychosocial support to be able to to know how to listen to the experience of children, because that's what the children wants, to be able to listen, to have someone that can listen to them.
Reading one of your reports, you were talking about how children often who have had a parent or someone die from HIV AIDS then suffer the fear that they might have the disease or someone else is going to die. Can you talk a bit about the psychosocial issues that they're faced with?
Yeah, oftentimes those children who's lost a relative or especially parent, they also have that in their mind that they're going to die soon, and they always have that fear that they're going to fear of getting extremely ill and fear of dying, and they just, it's constantly in their mind, and it's important that in those instances that there are people that they can turn to. Like in our experience, we've done a lot of peer education. We've organized peer education groups in schools. There are a number of clubs that they could join, so they could interact and with other children, because there's a tendency for these children to feel isolated and to be discriminated. And so those mechanisms are important to be there in the community, in schools, and for the youth, we've established some youth resource centers, so they can go there and do some. It can be purely recreational. It can be training on hero books where they're able to talk about their experience, and they're able to set goals for themselves. So to take them away from constant fear of dying, so there is hope that there is something that they could do about their lives.
And does ChildFund work through, obviously supporting different groups in the community, but does it work through the government or?
ChildFund as an organization have grassroots base. So we work with community associations that are based in the villages themselves, but we also work in partnership with various NGOs, community-based organizations, especially at the district. Our main partner at the district are the health department and the education department.
Mm-hmm. But giving a lot of support to caregivers as well directly. Yeah. Okay, we'll come back with some questions in a minute, but I'd like to move on to Bruce now. Bruce, you've just done a review of Fiji's national response to the HIV epidemic. With only 354 recorded cases of HIV in the past 2 decades, why focus on Fiji?
Fiji is an interesting contrast to what we just heard about, because there are not very many people with HIV, therefore not many children experiencing problems of parents dying. But in a similar way, there's a need for people to talk with one another and build community understanding about it. And one of the things that is a challenge for a country where there's not much HIV is to stop people panicking about it. Some of the worst stories we hear about stigma and discrimination are from countries with very low prevalence of HIV. I heard just last week in the Solomon Islands, a doctor told me that one of the people with HIV had been stoned. Now, I don't know whether they've been stoned to death, but that's a pretty extreme response. What I saw in Fiji was a really good example to me of a country with low prevalence of HIV dealing with it extremely well. And the way they're dealing with it, what matches with the story that we've just heard from Rouena, was government groups, civil society groups working together. There's a national network of people with HIV, FJN+. They're very visible, they're very well trained, they've had a lot of international support. And things happen like if a health clinic staff go out to a rural village to talk about HIV, they invite someone from that national network of people with HIV to come with them. And that reduces stigma and discrimination. It reduces the panic. People in the general community see, here's a person with HIV who says, I'm on treatment. See, the treatment works. It doesn't work if you don't get tested. Some people won't get tested, even groups that know they're at high risk, because they're scared of the reaction they're going to get from the clinic staff. And in the past, that has been a problem. But there is really good training now of clinic staff. One example of that was I met with a network of sex workers, SAN, I think it's Survival Advocacy Network. And they told me stories about how the clinic in Suva, the health staff had really bad attitudes, so therefore sex workers won't come to the clinic. I talked with the health staff and they said, well, that used to be the case, but we've had more training, we understand the needs of people better. Then I asked the Survival Advocacy Network people, well, what would you like me to say about that? What needs to be done? Their response was, we're part of a reference group for a national group which is going to train all of the health sector staff working on HIV. Training through the Fiji School of Medicine, so it's a university institution, training with assistance from Albion Street Centre, an Australian group, and the Sex Workers Network is part of the reference group. So they've told this group, we want you to make sure your training includes talking about our needs and making sure that we can confidently send sex workers to your clinic. The training will take place. The Sex Workers Network is part of an umbrella group that's called Women's Action for Change. They're an advocacy group working on gender issues. As part of their work, they have a theatre group that does community theatre. They're going to work with the sex workers to do some theatre that'll be presented in the training to the health workers, all about attitudes and how we can improve them. Then we have in Fiji a psychological support group. So again, the whole concept of psychological care comes in. It's not just about giving people a message about HIV, getting them tested, getting them on treatment. It's dealing with complex cultural issues. So the psychological support group, PCAS they're called, Pacific Counselling and Social Services, they're a non-government organisation that do a lot of the counselling, including in the government clinics. And they're going to be working, or they have been working, with this sex workers group doing outreach on the streets at night. They'll do some counselling out in the streets at night. Over time, that builds up the confidence of young sex workers to go to the government clinic, get a test, get some more counselling. And to me, all those things come together very well in the term UNAIDS is using is combination prevention. There's a combination of, yes, we need messages, we need communities to be involved. To do that, we need legislation that makes it possible for communities to be involved without discrimination. We need links to testing and to treatment. We need government clinics, community sector clinics, counsellors, doctors, all working together. And what I observed in Fiji is a lot of that stuff's happening very well, despite the fact that there are not many people with HIV. That leaves me confident that in the future, things will improve. And I think to top it off, when I talked with the groups from the network of people with HIV, how bad is discrimination here? They said, well, initially when people find out they get HIV, quite often their families will say they'll reject them. But our experience in Fiji now is that in almost every case, within 6 months, those people are back living with their families. They're back talking with their church groups. Church groups used to be hostile to HIV, used to say don't promote condoms. That's gradually changing. The church groups in Fiji are people's natural group to go to for support. So it's very important the churches accept them. And as I say, it's not thoroughly researched quantitatively, but my impression as part of that review team was they're starting to do things very well.
And how do, in Fiji, are the at-risk groups, the classic sort of sex workers, men who have sex with men and injecting drug users, or is it a different, how do you define the at-risk communities?
Interestingly, in Fiji, it's very hard to know is part of the answer, but there are clearly not the traditional risk groups that we might have, say, in Thailand or in Vietnam or other countries where all of those risk groups are really big. So Fiji has very few people injecting drugs, so they don't become a risk for HIV because there's not a critical mass. You need a critical mass of people from the one group. Fiji does have sex workers. They say they have lots of them, but I say, how many? And they say possibly 80. To me, that's not a lot. It's certainly not enough to have that critical mass of new infections that sustain an epidemic. Fiji has men who have sex with men, but the main group that works with them, Men Fiji, made very clear most of the men who have sex with men don't identify as gay, and many of them are married. And even that group that's set up to support them with prevention needs and help them understand about STIs and HIV, they have events linked with sporting groups where they talk about men's sexual health. So they don't specifically say we're here to talk with the men who have sex with men. So in that context, you can't count how many men who have sex with men are there in Fiji. That would require much more sophisticated research. But nor should the response be, we'll form a gay organisation and do what you do in a country where there are a lot of visibly identifiable men who have sex with men. The sex workers, there are women and there are transgender sex workers. They overlap with men who have sex with men. Their clients would often be men who have sex with men. But then you go and talk again with the clinic staff and the representatives of people with HIV, and the clinic staff say most of our clients with HIV are married men and women. And the Fiji network of people with HIV actually said to me, our members, and they have quite a big membership, about 40 people, they said the only thing common amongst our members is we all have HIV. So there are the traditional risk groups and there are some programs for them, but a lot of people are getting HIV just because, as in most cultures, people don't just have one sexual partner for the whole of their life. Things change, circumstances change, so there's no real common ground. But nor are there really thick networks that will, as I say, sustain an epidemic. So there are different people getting HIV. There's a need to have a balance in countries like Fiji, a balance, and it's the World Bank staff globally who have pointed out differences in different epidemics in different countries. What should you do in a country with low prevalence? And what the World Bank staff, particularly David Wilson, talks about is have a balance. Have some programs for the high-risk groups, some for the general community, but make sure that those programs are linked with this concept of testing, treatment, prevention, reducing stigma. And as I say, I think they're doing that.
Bill, maybe you can talk to this a little bit more, but PNG accounts for 99% of HIV infections in the Pacific, excluding New Zealand and Australia. That seems like an enormous proportion. Is it out of control or is it going to skyrocket?
Well, it's certainly not under control, under management. I mean, it is a very concerning situation. It is probably somewhat similar in a broader sense to the outline that we just heard about Fiji, but I'm prepared to be corrected on that. But nevertheless, it is a very worrying problem. It is very intrinsically linked to the decline of the primary healthcare system, however. One of the problems with care and treatment is you have to distribute treatments, you have to put a pill in the mouth of a patient every day, you have to account for it. They have to be recorded and assessed and managed, as it were, even at a rudimentary level. Now, if you haven't got a primary healthcare system that is functioning well, you don't have very much hope of getting the treatment out where it's needed and for the changes to be made. So this is a very serious problem. I know the World Bank, the Global Fund and the Global Alliance on Vaccines Immunisation is looking at how we might take some of the resources that are being applied to these big public health problems and talk about strengthening health systems. In some countries, Vietnam in our region comes to mind, they have a very good primary health system. So if they can have access to the treatments for HIV, you can be very confident that they will be distributed well and properly throughout the country. But in other countries, Papua New Guinea is one, we don't have that. So on one hand, it's important that we give more resources, or more resources are given for the access to antiretroviral therapies for HIV, but it's no use if they just turn up at the airport and sit in a warehouse and are not distributed. That's a waste of time and money and energy.
And issues like stigma as well, which seems to apply almost everywhere, is going to prevent people.
It is
seeking
very
it out.
important we understand this question about stigma and discrimination. It has been one of the great drivers of the epidemic from its first times in Africa, and then particularly when it hit the United States of America. One of the great drivers was this irrational, very unpleasant stigma and discrimination directed at those people who had HIV in general, but particularly in the communities where it first appeared, amongst gay men or sex workers or injecting drug users. Over time, in those countries where the stigma and discrimination has been removed or reduced, the rates have tended to come down. And when we talk about removing stigma and discrimination or reducing it, what we mean is criminalisation and changing the laws. If you criminalise sex work, if you criminalise men who have sex with men, if you criminalise injecting drug users, you get a very much higher rate of HIV transmission. So it is important in those countries that don't have yet a high HIV problem that they look very closely to what has worked in the world and start removing these barriers. This is very, very important. I mentioned earlier that in countries of Central Asia and the former Soviet bloc, the very harsh, punitive and illiberal laws they have about sex work, MSM and so on in those countries, injecting drug use, are driving this epidemic. And people are becoming sick and dying because of these regrettable and really highly counterproductive laws. And the same applies to injecting drug users.
And Papua New Guinea has passed a law, I believe, legislating against discrimination and stigmatisation of HIV. Has that had much effect?
Well, if you just judge by the nature of the spread of HIV, no. No, I mean, we are not seeing the results there that we should. The Papua New Guinea situation, however it came about, really, it came at a very late stage in the global pandemic and really should never have been allowed or permitted or mismanaged to get to the position it is now. But the problems that drive it in Papua New Guinea are complex. But I think if you looked at the Papua New Guinea HIV strategies and certainly the commitment of many people in Papua New Guinea to get on top of it, that's not quite the problem. It's not that the strategies are wrong or the commitment is not there, but I think it is very intrinsically tied there to a bigger problem about the health system. So as we look about how we might better assist Papua New Guinea to manage this, we do have to talk much more about the health system and hope that if we get that better, or if that becomes better, then the HIV problem will become more manageable.
I read somewhere that they were saying a high impact response is not going to have any effect in Papua New Guinea until things like violence against women are addressed and dealt with.
Yeah, but of course it's a bit then a problem of saying, well, everything is related to everything else, therefore nothing ever changes. Well, that's not the case either. I mean, the virus is the same wherever it is in the world, basically, and the instincts of people and their families not to get infected and for mothers not to have their children infected and to reduce problems, those instincts are the same. And I mean, they're the same in Papua New Guinea as they are in Paris or Potsdam. I mean, I don't think there's any great problem about the human response and how people will act, but it's a systemic problem. You do have to invest in a health system. If you can't invest in a health system, then you're not serving your people properly. And I think if Papua New Guinea can address that problem, then not only HIV and AIDS, but the whole raft of things that should be sorted out by a better primary health care system will start to improve. Until they do that, until the Papua New Guinea government comes to terms with that problem, though, I think it's very difficult to bring HIV under control.
More broadly, what's needed as far as funding and the Global Fund and an approach for the next?
Well, a lot more money. The efficacy of money has been proved. We've seen the results in our region and around the world in the last 10, 15 years. It's slowly getting better with some big exceptions. But this year, in the aftermath of the global financial crisis and the severe budgetary problems that are in the traditional donors, particularly in Europe, the Global Fund will go to donors in October in New York for their 3-year replenishment. The last replenishment was in Berlin in 2007 at the height of the economic boom. The donors were very generous in Europe, Japan, the United States, and they put in 10 billion for the last 3-year period. Now in October, the Global Fund will go to donors, same donors, the Bill and Melinda Gates Foundation and so on. And what really is required at a minimum to realise the investments and turnaround we've made is about 20 billion US, 20 billion US. Now it is very difficult to see the Global Fund and the donors coming up with that amount of money. It would be very regrettable if it fell short, but that is the big political question. We know the strategies work. We know that 2.5 million people are on ART who wouldn't be on antiretroviral therapies, and they must be on that forever, thanks to the Global Fund. We know we've recorded these great steps forward, and we know that if we fund it properly, we would be, by 2015, able to talk seriously about eliminating mother-to-child transmission of HIV and AIDS. Presently, 400,000 children are born with HIV, so we know how to do that if we have the money. So the world faces a big question. Are we going to put resources into things like the Global Fund, things that work, and where are these resources going to come from? Which other parts of national and international budgets should be reduced or changed or altered to allow more of these resources to be put where they demonstrably, clearly, on the evidence, are working to bring about happier and healthy people and countries.
And what's the role of the Pacific Friends of the Global Fund?
Well, the Pacific Friends of the Global Fund is established with the support and encouragement of the Bill and Melinda Gates Foundation and the Lowy Institute here. It's one of several similar organisations around the world that exists to advocate, to knock on the doors, to nag and make the case for a bigger replenishment for the Global Fund in America and Europe, Japan, so on. So we have been talking assiduously with both parties to the Australian election, and when a new Australian government is put into office sometime in the next week or so, then we will certainly go with our other colleagues from the development assistance NGOs and so on, Oak Tree Foundation, so on, and put the case to the new Australian government that we should greatly increase our support of the Global Fund. And if we do that, then we can have a big impact in the world position, but the Global Fund is then better able to fund prevention, care and treatment programs in Papua New Guinea or Fiji or Southeast Asia as well. So we will certainly make that case to them and hope that they respond generously and magnanimously.
I'd like to open up to questions from the audience if anyone wants to.
My name's Margaret Duckett. I'm CEO of AFAP. I agree that the amount of money that's been going in has really been improving the responses to the epidemic quite drastically. We've had a large program in 6 countries in Africa for the last 6 years. I visited Malawi, Kenya and Mozambique in March this year to review specifically the HIV/AIDS component of those programs and to give advice on how to improve it. And all our partners talked about how the money, particularly for treatment, had started changing the dynamics of stigma and discrimination, started actually meaning that a whole range of messages were taken on board. What I, however, am really concerned about is that not enough of us, not enough of the development agencies, not enough of government, not enough of the funding bodies are promoting heavily the use of things like the NGO Code of Good Practice, the Code of Good Practice for NGOs responding to HIV/AIDS. It provides a whole range of assessment checklists on are you doing the best you could do in the way you design your program and deliver your program. And there are individual checklists depending on if you're working with girls or boys, men or women, focusing on HIV/AIDS, focusing on drug use and HIV/AIDS, focusing on home-based care, all about 25 different aspects of HIV/AIDS. I think it's a fabulous collection of tools. I was promoting it to our partners, none of whom had actually really been aware of even its existence, let alone then started using them. And so we're now trying to roll that out through the 25 countries my agency is working in. But I think that more people need to be doing that, because they're the practical things that will make a big difference to really ensure that people living with HIV/AIDS are part of the design and the delivery of the programs at the grassroots level. That's where it really makes a difference. So there's a whole range of those sort of things that we've learnt in Australia, we've learnt globally, but making sure that people at the grassroots level, when they're delivering the programs, incorporate them. They've got the money, but we need the things to make it easier to make sure you're doing everything that we know is best practice.
Thanks. Does anyone want to respond to that?
I think I'd like to reinforce what Bill's saying about the funding going where the evidence shows it makes a difference. And I think what Margaret's talking about is, even at a local level in a community group, what are you actually doing? And that can be taken up to a national level. I did some work last year with a World Bank program that helps countries develop national strategies on HIV. Now, why is the World Bank doing that? Because the World Bank's concerned at, yes, we need more funding, but how much money is being wasted by countries doing general community education in all schools when most of their epidemics are about injecting drug users, and they're doing nothing. Russia was an example cited. Over 80% of people with HIV in Russia are people who inject drugs. But the national government's not spending 1 cent on helping those people. Other global donors are, and this is where the Global Fund can be important. So there are questions at national level of not every country has to do everything because the epidemics are different. Questions about when you have a general community discussion. And again, I go back to, just because I'm familiar with it, having just been there, Fiji, low prevalence setting. You get churches talking about HIV, that's great. But do churches talk with their young people about condom use? So it's not just a question of funding. It is, what are the groups doing? I think Margaret's raised a really important point there, that we're not just trying to raise awareness about AIDS, like that's a good thing always. We've got to a stage now where in every country we know there are specific challenges. Where funding's being improved, again, thanks to the Global Fund largely, that we're getting much better surveillance, much better understanding of what the challenges are in each country. But then that's got to be matched with, take that evidence to the people in that country and get them to stop just talking about AIDS is a bad thing, let's stop it. And let's talk about compassion, and let's get communities talking about how do we support the orphans. I think the stories about supporting orphans are really interesting because there's no set way to do that. There's no template to follow.
Would either of you like to add anything?
I just want to stress the point where that's where the networking among different groups are really play an important role in terms of using the funds more effectively. Because you, in that network, in the district or in, whether in community level, you would know who is doing what and who is providing what. So you avoid duplication of services, and you can educate the community on where to go or what to do in terms of, depends on what they need.
Bill, you were an architect of Australia's response to HIV, and it was very successful. Are there strategies from that you can see easily applied to other countries, say in the Pacific, or is it completely different?
Definitely. The first element of the Australian response all those years ago was that there would be an Australian response. That was a very significant step forward at the time, because that was not universally thought to be the case. It was just thought to be another public health problem. But when we realised the nature of the problem, then we said there should be a national strategy, that it should try to cover care and treatment and research, both medical and scientific and social, but most importantly that it should stress prevention. And I can't emphasise that enough. I mean, prevention is about persuading young people predominantly to make small changes in behaviour that allow themselves to be protected from HIV infection. And this is not something you decide will be just one advertising campaign, or you put out a press release and say there must be a prevention campaign, a bit like Bruce is saying. You can't just make the pious hope. You have to, it's hard grinding work. And the networks and the people who talk with young people, and particularly in relation to sex and drugs and so on like that, those people get out there at 3 in the morning, and hundreds and thousands of volunteers and other people who are well motivated, well informed, get out there and they make the change happen. And then if people have access to condoms and to clean needles and remove these silly stigmatising and legislative barriers to this stuff, then over time you get something going. And while other countries, it wasn't just Australia that did this, but the countries that did that in the mid-80s and looked at it as a coherent problem, removed the barriers, stress prevention, were really rewarded very quickly with very substantial fall-offs in new HIV infections and therefore deaths from AIDS. And that wasn't just in the developed world, although that was where it first, that fall-off manifested itself, but many countries in the developing world, or some countries that had learnt those lessons and saw what had happened and applied them, were then also rewarded with very great falls in HIV. So in Australia all those years ago, we were one of several countries and regions that stumbled towards the right response. And thanks, I think Margaret's point is very important, that the intellectual property, as it were, that was developed at that time and by other people in similar jurisdictions is really the dynamic force that should inform what UNAIDS does, the Global Fund and the World Bank. And that is what is, and WHO, and that is what is happening. You know, they've learnt those lessons, finally. Took a long time and a lot of dead people before they did, but finally, and then the money's got to come in behind that. And that will take another 25 years or 30 years. It won't be resolved anymore next week or next month. So that's what I take.
Any other questions from the audience?
Thank you. My name's Sue Dwyer. I'm the Maternal and Child Health Advisor for World Vision Australia. And I think you've raised some really interesting points, and I would like to ask both of the men in the room about the church partnership issues that you brought up, because in Papua New Guinea we really know that stigma and the addressing of stigma around STIs, sexual behaviour in general, men's responsibility for their families and their family violence can be addressed and potentially could be addressed with lessons learned from your Fiji experience. So that would be one question I'd love to hear from both of you around your feelings around what could be done or is being done that we don't know about. And my other question is a bit more technical. I'm not sure whether you can answer that. It's around, again, it's around the men and boys impact and behaviour change, which you've mentioned. But two things, the prevention of parent-to-child transmission instead of talking about mother-to-child transmission, because I think that brings a whole new message to the debate. And the second thing is circumcision and men in PNG. Obviously, I'm an advocate for the women of PNG, being a maternal and child health advisor, with high maternal mortality rates in PNG being out of control. But I'd really like answers to those couple of thoughts.
Bruce, would you like to start with the first one?
Oh, we'll start with the churches. I think the main things I would want to say about the churches, one I've already said, is that in many communities all around the world, the church is the only local community group people have. So if the churches are not engaged, the community's not engaged. And I think we've moved well beyond where we might have been 15 years ago. I know in the early stages of the epidemic in Australia, there were clashes between the church groups and the gay groups and the sex worker groups. That got resolved over time. What I just learnt being in Fiji is that within the churches there are all sorts of different perspectives. So it's not one monolithic church position on promoting condom use. And what I found particularly interesting in one of the district AIDS councils was there were two pastors, I think they called them, not ministers, pastors, both from different Christian denominations in Fiji, both on like a local AIDS committee, the district AIDS committee. And I asked them about what's going on in the churches because I was surprised at a general discussion, and again, this community interaction. Within the room were about 10 people, Ministry of Health people, doctors, police, and these 2 church ministers, church pastors. And I said towards the end of our meeting, well, I'm surprised to hear the churches talking openly about community awareness, and when I asked where are condoms available, they weren't saying there's condoms available in the churches, but these 2 pastors knew. They said, yes, they're available in the stores. Yes, they're available in the clinics. So I asked them something similar. Well, how do you get the churches being responsible about this? And what I found interesting was their answer. They said, we're quite aware, and so are most of the church people in the cities in Fiji. But the further you get out into rural areas, the less educated are the people and the churches. And so they were recognising it from within the church themselves. We have a problem and it won't be solved overnight. But it won't be solved by people just saying the church is the problem.
And would you like to address the second question as well?
The second, let's talk the other. The involvement of men in reproductive health is a really important issue within the HIV and STI and just reproductive health sphere. And some of my colleagues at Burnet Institute have been involved in working with UNICEF and UNFPA and WHO to look at how can we get men to be more involved in reproductive health. We have a research project at the moment in Indonesia that's trying to promote getting men to come to antenatal clinics and look at what are the barriers, what will help to achieve that. In Fiji, again, I heard an example of this one group, and I can't remember which group it is, but there's a group that's doing something very similar with a pilot program of women in Fiji. They've got a fairly good health system, so women are often getting 2 or 3 visits to antenatal centres during the course of their pregnancy, whereas in many countries it's just 1 visit at the last minute when they're about to have childbirth. So women are coming 2 or 3 times. They're encouraged to bring their husbands with them, but the clinics are just learning how do you make that possible. So they've said, well, we've gone from they used to just wait outside the clinic to now we have a special waiting room that the men wait in, to now we're a year later really looking at what's actually happening inside the clinic. Is this a male-friendly environment? Because a lot of antenatal clinics are all about women. And I think the questions of gender-based violence, similarly, we look at gender far too often as though it's just about women. And changing men's attitudes is equally an important part of gender. One of the issues with prevention of parent-to-child transmission is if a woman has HIV, again, people who have HIV recently infected have a high viral load. If a woman's had HIV for 2 years and then is pregnant, the chance of her baby getting infected is much lower. So what's the key challenge? To stop women getting infected while they're already pregnant. And what's one of the main reasons they do get infected is because all around the world men think it's dangerous to have sex with your wife when she's pregnant. Now that's not the case, but men think that's dangerous, so they go and have sex with a sex worker, then they get infected, then they come back and they do have sex with their wife after all, and then she's infected very recently, and that vastly increases the chances. So I fully agree with the concept of parent-to-child transmission, not mother-to-child transmission, but I also know globally people just think PMTCT, they use that abbreviation, and it goes back to it's all about mothers and children. It's not, it's about parents. And also what my colleagues at Burnet have found in a number of countries is if you talk with men, rarely do people bother to talk with men about reproduction, but when you do, you say to men, you don't want your child to be infected when it's born. Men will agree with that. We've got to take that initiative. So I'm glad that World Vision are starting to think about similar issues. It's great.
Rouena, do you want to add anything to that?
From our experience in the maternal and child health, we've got some programs also that are really focusing on male involvement in maternal and child health, and because it's true, they have to be really involved so they can understand what's going to happen to the child and to the mother. Yeah.
And do many of the children who go through ChildFund programs themselves become advocates or educators?
Yeah. From the story of those two boys, they are in school at the moment, but also they are actively involved in educating their fellow children in the communities and school.
I'd just like to maybe put not the same question, but a similar question back to Bill, who talked about the importance of establishing health systems. And I think this whole discussion of men's involvement in reproductive health is, to me, a really good example of where, for all sorts of reasons, a lot of money globally is now being channeled into HIV. And there's been some criticism of that because there are other health needs as well. And I think improving reproductive health to involve men, you might be doing that to prevent HIV transmission to babies, but in doing it, you're also improving the health system for reproductive health. And I just wonder, Bill, whether you can give us some other examples of how HIV funding can help strengthen health systems, even though the starting point's HIV.
Well, certainly the question of testing, when treatments came along, there was testing. So there was an incentive to be tested because you would have access to treatment. That was the idea. And therefore the whole apparatus of laboratories and clinics and so on that where people could be tested and things could be assessed, and if they were distributed around the countryside reasonably, as in many cases they were, well, the laboratory equipment provided for HIV, of course, becomes laboratory equipment available for all sorts of other things. And I've seen that, I think in Vietnam particularly, where the investment was made for HIV reasons, but the laboratory and the upgrading of the testing and clinical assessment that was put in for that then obviously helped across the whole range. And if you put another technician that might be looking at reproductive health questions for testing and so on, that was a good step forward. And of course the important investment that's made in HIV is in clinical people, clinical expertise. Not so much the doctors, but the nurses and the paramedical and the other people who are out there implementing this response. And the training of these people is a really important factor. You can have a very nice spreadsheet about a health system, you can have a very nice strategy, but it doesn't work unless you have people in the village or in the regional or district centre, and if you have got those people, then generally you've got well motivated and very good people who are prepared to support not just HIV or malaria or TB, but the whole range of health system responses. If I could just say on that question of the church, I think the question of churches is a vexed one. In the Australian response and many responses were immeasurably strengthened by the people who were closest to the problem being loving, caring and compassionate. And in Sydney, I know particularly, this was particularly so with nuns and people in churches and so on at hospitals like St Vincent's and elsewhere. My view always is the people who are closest to the problem are very well capable of getting on top of it, of moderating the opinions of their families and friends, and of young people particularly. And in many countries, the churches are loving and compassionate people at the community level who just get on with the job and are pragmatic and sensible. The problem with churches, as in so many other institutions, whether it's police or politics or medical profession, is the higher up you go, no pun intended, the more theologically involved you become about, questions of sin and good and bad and all the other sort of stuff. And this is really deplorable because at the high institutional levels, not at the base level, but at the high institutional levels, there's no doubt that some of the churches and some of these other institutions have been really poor. They have contributed to the spread of the HIV problem. They've not diminished it. And they have supported stigma and discrimination, not removed it. So I do distinguish between the body and soul of the people who are often associated with churches in developed and developing countries, who have been magnificent and wonderful in the way they've approached the HIV problem, I do distinguish them from the relatively small handful of rather very powerful people, often regrettably mostly men, who have not distinguished themselves in the HIV response. And it comes to a last point about the role of women. There can be no getting on top of HIV without women. Women are absolutely central to the response. They were in Australia. I appreciate the point about men and fathers and mothers and child transmission, but women predominantly are the carers, the protectors, the nurturers, and the people who speak a lot of common sense about all of these questions. And wherever women are at the top of and forefront and top of the response, things get done and stuff happens and the problem becomes less. And where they're not and they're excluded, as I regret to say I think happens in institutional sense in countries like Papua New Guinea, then you have real problems. So anything that doesn't have women at the heart and soul of this is not going to work anywhere. Didn't work, hasn't worked and won't work.
We're going to have to leave it there, unfortunately. I think we could go on for quite some time, but thank you very much to our panel, Bill Bowtell, Bruce Parnell and Rouena Getigan. And thanks very much to our audience here in Sydney, and hope that you can join us again next month for Praxis. If you'd like to subscribe to the podcast or watch episodes online, you can go to worldbank.org/Praxis. Thank you. Goodbye.